Hello, my name's Janetta Webb and I'm the pelvic floor physiotherapist at the Jean Hales Medical Centre. Today I'm talking to you about dyspareunia from my perspective. Dyspareunia is any discomfort that a woman experiences during intercourse. On this slide are common quotes that I hear from patients when they come for initial consultation. Patients can present at any time in their lives, from their initial sexual activity right through to the postmenopausal years. Some common presentations that I have seen. Firstly, women in their 20s who have been in a new relationship for a reasonable period of time and have been experiencing recurrent candidiasis, and then present with dyspareunia. Nulliparous women who are wanting to conceive but have had issues with dyspareunia since they have first become sexually active, perhaps due to poor education in terms of sexual function, or cultural or religious upbringing that suggests that sex is taboo. A frequent presentation is women with endometriosis who've initially experienced deep dyspareunia, but then it has also become a problem in the superficial tissues of the vagina. Dyspareunia is often an issue for women who are experiencing other pain syndromes, such as fibromyalgia, bladder pain syndrome, irritable bowel syndrome, or migraines. I often see women for whom dyspareunia has developed in the perimenopausal or postmenopausal years, and also during the postpartum time. It's interesting to note that this is a less common presentation, and I wonder whether this is purely due to an acceptance, perhaps, of the fact that sex is supposed to be painful after having a baby, which of course it's never supposed to be painful. Considering the etiology of dyspareunia, firstly we need to consider infection, such as vaginal thrush or urinary tract infections, particularly when they are recurrent. Inflammation can also be a cause, as can hormonal changes, particularly atrophy. Anatomical differences, such as remnants of the hymen, prolapse, or uterine fibroids, can contribute to dyspareunia, as can muscular issues, particularly pelvic floor muscle pain, which is often referred to as vaginismus, or also overload of the pelvic floor, as with an extremely strenuous gym program. Iatrogenic changes with pelvic radiotherapy or surgery must also be considered as a cause. Continuing to look at etiology, neurological causes, particularly pudendal neuralgia, connective tissue or immunological causes such as Sjögren's, and gynecological diseases, for example endometriosis, as mentioned before, or lichen sclerosis. Chronic pelvic pain frequently also contributes to dyspareunia, as does direct trauma from an accident. Noteworthy is that it is estimated that up to 60% of women who present with dyspareunia have experienced sexual abuse in the past. And allergic reactions to diet or products used in the vulval area can also contribute to dyspareunia. We also need to consider psychosexual issues which may contribute to dyspareunia, particularly depression, anxiety, and a history of sexual abuse, as mentioned before. These issues also need to be considered in a woman's relationship: mismatched libido, lack of intimacy, inadequate arousal, and conflict in the relationship. But do note that these issues can arise as a result of the dyspareunia, as well as contributing to ongoing dyspareunia. The role of the physiotherapist includes initial assessment of the issue, education of anatomy, causes of pain, the body's response to pain, then follow. It's important to discuss triggers with the woman, and common presentations can include, as well as intercourse, bike riding, wearing tight clothing, or prolonged sitting. The discussion of vulval skin care comes here, avoiding the use of perfumed soaps, vaginal deodorants and powder. Using a low allergy diet if this is appropriate, and also care with pads and the use of perfumed toilet paper. I would always recommend to women that they wear cotton underwear only, and cotton pads and tampons, if the woman is using these, are readily available. At initial consultation, I would suggest that the woman and her partner have what I call a holiday from having penetrative sex, but I encourage the continuity of intimacy in the relationship as long as there is no pain caused. If there is any hypersensitivity in the vulval skin, it's important to assist with desensitisation of this. This may be with perineal or internal vaginal massage, and at this time the use of topical vaginal estrogens such as Ovestin cream can be helpful, particularly if there are atrophic changes. Muscle function needs to be retrained. How to let the pelvic floor muscles go, breath awareness, awareness of when the muscles are contracting and when they're releasing. And I find visualization of correct muscle function can be helpful. So it may be a silk scarf slowly floating down to land gently on the grass. It may be coming down a slide. It may be a waterfall or a scale starting high and moving down low. It's important in the retraining of muscle function and desensitisation that care is taken to ensure initially a relaxing environment, but with progression of treatment, the woman needs to still be able to keep her pelvic floor muscles at normalised levels of tone in any environment. We need to address the issues of elasticity of the vaginal skin or any scar tissue, and to relieve any pudendal nerve entrapment that is thought to be present. General pain relieving techniques and the use of exercise for pain relief is also very important to discuss. A full pain history is taken. Was the onset of pain sudden or gradual? Is the pain generalised or localised to a particular area in the vulva, which would be called vulvodynia? And is it provoked by particular activities or unprovoked, or sometimes can be a mixture of both? Women will describe their pain. Common words used are burning, cutting, throbbing, tearing and itching. And also, as mentioned before, any particular triggers to the pain. Does it occur on arousal, with superficial pressure on the vaginal tissues, with deeper penetration? And I'm also interested if the woman is able to use tampons, and how her experience is of pap smears or pelvic ultrasound. I use a numerical pain scale of 0 to 10, with 0 being no pain at all, 10 worst possible pain. I'm interested in factors that exacerbate or reduce the woman's pain, and also when it does come on, how long it lasts for. And finally, if there have been any factors that have been particularly helpful in the past that have reduced dyspareunia. It's very common for women to also report bladder and bowel dysfunction. As mentioned before, in the medical history, issues with fibromyalgia, migraines or temporomandibular joint issues commonly occur. Surgical, obstetric history are important to ask, as well as any medication that may be being used to assist with the pain, or used for any other issues. And a history of general exercise that is currently being performed. The initial examination will be an examination of the skin, noting any erythema, scars, fissuring, indrawing of the perineum, or any dermatological issues such as lichen sclerosis. A palpation of the external skin to note any areas of tautness, hypersensitivity will be performed, and a Q-tip applicator may be used to check for provoked vulvodynia or vulval pain when placed in particular areas of the vestibule. A muscle palpation is performed, firstly looking at contraction and relaxation, but initially, if the pelvic floor muscles are already contracted, you may not be able to see a contraction and relaxation. Palpation of both the superficial and deep pelvic floor muscles is performed. The tone of the muscles is determined by the compliance or compressibility of the muscles. It's often asymmetrical. Taut bands may be palpated in the muscles, and there will usually be pain on palpation or stretch to the muscles. Trigger points may be palpated in the pelvic floor muscles as well. And an initial assessment of strength is performed. Pelvic floor muscles are often weak when they are overactive because of their constant spasming or contraction. Initially, strength will not be a focus of the rehabilitation program, but certainly that is something that needs to be considered at a later date, particularly if bladder or bowel dysfunction or prolapse are issues. Complete rehabilitation of the pelvic floor muscles is important to reduce the susceptibility of the muscles becoming overactive once again. I mentioned trigger points before. So these are areas in skeletal muscle that are actually at the motor end plate where the nerve enters the muscle. They're areas that are of localized tenderness that's part of a tense band, and there's quite specifically increased resistance in the area. On palpation of a trigger point, the patient's pain is evoked, and there's a painful limitation of both active and passive movement of the muscle. Pain in the pelvic floor muscles in their trigger points can refer pain to the coccyx, the anus, the sacrum, and throughout the vulval area. Trigger points are usually associated with muscle weakness. And it's interesting to note in this particular study that 88% of patients with chronic pelvic pain had trigger points in their pelvic floor muscles, their abdominal muscles, and their hip muscles. As mentioned before, anatomical education is extremely important. Discussion of pain reactions in the body, so the fear-pain cycle and how this will be contributing to the ongoing issues with dyspareunia, as well as the body's response to pain, so particularly wind-up and the issue of central sensitization, particularly if the woman is experiencing other pain syndromes. Physiotherapy will progress to manual therapy techniques such as myofascial release of the pelvic floor muscles and the surrounding fascia. Trigger point therapy to actually reduce and eliminate the trigger point in the muscle, and the normalization of the sensation of stretch, so that rather than the woman experiencing stretch of the vaginal tissues as being uncomfortable, she comes to feel this as a normal sensation. Research looking at the manual therapy techniques to the pelvic floor unfortunately is poor at this stage, but continue to keep an eye on the Cochrane database for ongoing randomised controlled trials. As well as manual therapy, adjunctive therapeutic techniques may be used, such as the use of dilators or trainers or accommodators, whichever word you would like to give to these. This assists with gradual sensitization to a slightly larger cylinder being gently inserted by the patient into the vagina. Progressions for use of trainers as well as increasing size will be progression to using the trainers in different positions and with movement. Trainers can also be extremely helpful in the gentle stretching of scar tissue, or in the case of a shortened vagina or vaginal strictures, can also assist with the elasticity of vaginal skin. Discussion and suggestions of different lubricants to women can be very helpful, such as the use of silk, available in supermarket or pharmacy, or olive oil. Biofeedback techniques, particularly surface EMG, can be most beneficial to assist women to have a perception of when they're contracting and when they're releasing their pelvic floor muscles. TENS, or transcutaneous electrical nerve stimulation, is a very commonly used tool for the management of all types of body pain, but certainly has its place in the management of dyspareunia. And also the use of heat and cool packs. The aim of treatment is to, of course, progress to comfortable intercourse. And not only are you wanting women to progress to comfortable intercourse, but also to find that intercourse is enjoyable and no longer an issue in their relationship. To look a little more closely at pudendal neuralgia, this can occur in response to inflammation or infection, or nerve entrapment, which could occur between the sacrospinous and sacrotuberous ligaments in the pelvis, or under the fascia of the obturator internus muscle. It can also be due to overactive pelvic floor muscles. Common symptoms associated with pudendal neuralgia include increased pain in the vulval, sacral, coccygeal or anal area on sitting with defecation, riding a bike or an exercise bike, wearing tight clothing or tight underwear, during exercise at gym or with sexual arousal. Most women report that pain reduces when they're standing or sleeping. Pain can be unilateral and can be described as burning or itching. The treatment for pudendal neuralgia includes physiotherapy, as mentioned before, including release of the pudendal nerve, as well as pudendal nerve blocks and possibly the injection of Botox to the pelvic floor muscles. A multidisciplinary approach to the management of dyspareunia is extremely important, starting with the GP, particularly looking at ongoing issues with recurrent urinary tract infections, thrush. But do take care with ordering pelvic ultrasounds, because many women who are experiencing dyspareunia will actually have significant discomfort when using a vaginal probe. Gynecologist, urologist, a psychologist with an interest in this area of work, gastroenterologist, dermatologist, and a pain management specialist who also has interest in the management of pelvic or gynecological pain can be very helpful. There are public pelvic pain clinics at Monash Medical Centre in Moorabbin, the Royal Women's Hospital, and also the Mercy Hospital for Women. And note that if you are wanting to refer a patient to a physiotherapist, it's important to ensure that she is a pelvic floor physiotherapist. The Australian Physiotherapy Association website has a register of all such physiotherapists in Australia. Looking at pharmacology, topical estrogen is probably the most commonly prescribed medication to assist with dyspareunia. If this is not appropriate, or as well as this, vaginal moisturisers such as over-the-counter Replens can be used. Research looking at the use of oral and particularly development of topical Endep cream continues. Lignocaine 2% gel over the counter can be very helpful to assist in the management of dyspareunia. I would never suggest that it's used as an initial management tool, as investigation as to the causes of the dyspareunia are important initially. Research has investigated the use of diazepam vaginal pessaries, but this RCT showed that there was no significant difference between a diazepam pessary and non-diazepam. Injection of Botox to puborectalis muscles has certainly been shown to be extremely effective if more conservative treatment techniques have not been effective, as well as pudendal nerve blocks, as mentioned before. So let's look at some case histories. Isabelle presented, who is a 28-year-old nulliparous woman with dyspareunia. This had been a problem for some time. However, this was her first presentation to her GP, having never felt comfortable to discuss it before. She's had issues with recurrent vaginal thrush since being sexually active 9 years ago, and also has a history of anxiety for which she has seen a psychologist in the past. On questioning, she revealed issues with urinary frequency and urgency, and felt that she also had irritable bowel syndrome. Her GP helped her with the treatment of the thrush with repeat swabs until it had been eliminated. MSU was also performed to ensure that the urinary symptoms were not indicative of a UTI. Vulval skin care was discussed and consideration of referral to a gynaecologist and also a gastroenterologist for discussion of Isabelle's bowel symptoms. In this situation, it may be necessary to refer Isabelle back to speak to the psychologist for continuing management of her anxiety, and she was referred to the pelvic floor physiotherapist for assessment and management of overactive pelvic floor muscles. Diana was a 58-year-old postmenopausal woman, a para 2, who presented with dyspareunia, the onset being approximately 3 years ago when she commenced a new relationship, having not been sexually active for a few years. She described vaginal itchiness, for which she had used many over-the-counter treatments with very little effect. She also reported vaginal laxity and reduced sensation during intercourse, as well as intermittent low back pain. On examination, atrophic vulval changes were noted, as well as lichen sclerosis and some vaginal prolapse. On palpation, it was found that her pelvic floor muscles were overactive. Diana was referred to the gynaecologist to assist with the management of a number of her issues, but prior to this prescribed topical estrogen. She also attended for pelvic floor physiotherapy, where it was found that she had developed overactive pelvic floor muscles, initially thought to be in response to the atrophic changes in the vagina, causing the dyspareunia, which had then contributed to the pelvic floor muscles becoming overactive in response to pain. It's interesting to note that at the same time as commencing her new relationship, Diana had also started to attend gym 5 days a week and was performing exercises with extremely heavy weights and at a high intensity. So these were reduced to reduce any overtraining of the pelvic floor muscles. Thank you for listening to this presentation today. You'll see here some useful websites as well as our Gene Hales for Women's Health website. Thank you.